This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal BMC Neurology, published in 2026. The paper is titled Revision Rate and Postoperative Volume Development of Chronic Subdural Hematomas After Burr-Hole Craniotomy in Combination with Tranexamic Acid versus Surgery Alone, a Single-Center Propensity Score-Matched Analysis.
This is a timely topic, Alara. Chronic subdural hematoma, or CSDH, is one of the most common traumatic intracranial hemorrhages we see, especially in Western industrialized countries. With our aging population, it's becoming a massive challenge. We all know the frustration of a successful burr-hole evacuation, followed by the patient returning weeks later with a recurrence.
Exactly. The reported recurrence rates requiring revision surgery range anywhere from 2.3% all the way up to nearly 39%. That's a huge margin of uncertainty. This study, coming out of the German Armed Forces Hospital in Ulm, specifically looks at whether tranexamic acid, or TXA, can help lower those numbers when used as an adjuvant to surgery.
Before we dive into the data, let's refresh our listeners on the pathophysiology. The paper does a great job of explaining that CSDH isn't just about a simple rupture of bridging veins.
Right. It's more complex. It starts with an injury to the dural border cell layer, that specialized connective tissue between the dura and the arachnoid. That disruption kicks off an inflammatory response in angiogenesis. You get these pathological, thin-walled capillaries that are prone to rupture, causing microhemorrhages.
And that's where the hyperfibrinolysis comes in. The paper describes a self-perpetuating cycle of cellular proliferation, angiogenesis, and hyperfibrinolysis. Basically, the body's own system for breaking down clots, plasminogen activation, prevents the hematoma from stabilizing, leading to progressive enlargement.
Which is the rationale for using TXA. As an antifibrinolytic agent, it inhibits that plasminogen activation. If we can stop the hyperfibrinolysis, we might stop the recurrent microbleeding that drives the expansion.
But it's been controversial. Some studies show promise, while others haven't seen a benefit or have even raised concerns about mortality. So, Ilara, how did the authors of this study set up their investigation?
It was a retrospective cohort study of adult patients treated between 2012 and 2024. They looked at patients who underwent burr-hole evacuation with subdural drainage. They had two groups, an intervention group that received oral TXA starting within 48 hours post-op for at least 30 days, and a control group that had surgery alone.
And they used propensity score matching, which is crucial in these retrospective designs to minimize bias.
Precisely. They matched 1-to-1, ending up with 73 patients in each group. They balanced them for baseline characteristics like age, comorbidities, and preoperative hematoma volume. The primary outcome they were hunting for was the need for revision surgery within 90 days.
So what did the numbers show? Did the TXA group fare better?
They did. In the TXA group, the revision rate was 8.2%. In the control group, it was significantly higher at 19.2%. That gave them an odds ratio of 0.40.
That's a pretty substantial reduction, cutting the risk by more than half. However, I noticed a detail in the results regarding the precision of that finding.
Good catch, Dr. Aris. The paper notes that the 95% confidence interval was 0.14 to 1.12. Even though the p-value was 0.042, because that confidence interval marginally crossed unity, the authors are very careful to describe these findings as hypothesis-generating rather than definitive.
That's an important distinction for our residents and students listening. When the interval crosses 1.0, we have to be cautious about the statistical precision. What about the timing of these recurrences?
Interestingly, the median time to revision was 8 days in the TXA group and 11 days in the control group, so if they were going to fail, they tended to fail early.
One of the unique aspects of this study was that they didn't just look at revision rates, they also tracked postoperative volume development. This is something we often discuss in the clinic. Does the drug actually make the remaining fluid disappear faster?
That was a key secondary outcome. They measured hematoma volumes preoperatively, postoperatively, and at a 1-month follow-up using cross-sectional imaging. They found that preoperative and postoperative volumes were comparable between both groups, and at the 1-month mark, there was no significant difference in the absolute volume reduction between the TXA group and the controls.
So the TXA didn't necessarily shrink the residual hematoma faster than the body would naturally do after surgery.
Exactly. The study suggests that while TXA might prevent the self-perpetuating cycle of rebleeding that leads to a surgical recurrence, it doesn't appear to significantly influence the short-term clearance of the fluid that's already there.
Let's talk about safety. That's always the concern with antifibrinolytics in an elderly population, risk of thromboembolic events or increased mortality.
In this cohort, mortality was actually numerically lower in the TXA group. There were 0 deaths in the TXA group compared to 1 death, or 1.4%, in the control group. No significant increase in adverse outcomes was observed, which supports the safety profile of the 30-day oral regimen they used.
It's worth noting the specific dosing mentioned. They used oral TXA without an intravenous loading dose. This is a bit different from some other protocols that use IV transitions. It's a very practical approach for a neurosurgical ward.
It is. And since the medication was started within 48 hours and continued for a month, it covers that critical window where the dural membranes are still highly active and prone to microhemorrhage.
So, looking at the conclusion of the paper, where do we stand?
The authors conclude that adjuvant TXA therapy is associated with a lower rate of recurrence requiring revision surgery without an observed increase in mortality. But again, they emphasize the need for prospective randomized studies to confirm these findings and to define the optimal dosing strategies.
This study adds another piece to the puzzle. For a resident or a student, the takeaway is that our surgical technique, the burr hole and the drain, is only part of the story. The biology of the dural border cell layer and the hyperfibrinolysis of the hematoma content are just as important for long-term success.
And while TXA looks promising in reducing the need for us to take the patient back to the OR, we shouldn't necessarily expect it to change the imaging appearance in the first month.
Right. Don't be discouraged if that 1-month follow-up CT still shows some fluid. The goal of TXA here is stability and preventing that self-perpetuation of the bleed.
One final point the paper makes is about the limitations. Being a single-center retrospective study, even with propensity score matching, there's always a risk of unmeasured confounders.
True, but the match they achieved for 73 patients in each group is robust for this type of clinical research. It's certainly enough to make me consider the role of TXA more seriously in my own postoperative protocols for these high-risk elderly patients.
Definitely. It's a low-cost oral intervention that targets the very mechanism of the disease.
Well, that's a deep dive into the BMC Neurology paper. Thank you, Dr. Hilara, for breaking down the methodology and those nuanced results.
Thank you, Dr. Aris. It's a fascinating area where medicine and surgery really intersect.
To our listeners, remember to check the show notes for the full title and citation of the study. Join us next time on the Neurosurgery Hub podcast as we continue to explore the latest evidence in our field. I'm Dr. Aris.
And I'm Dr. Hilara. See you next time.